We are now on the vascular surgery chapter. A 54-year-old right-handed laborer notices coldness and tingling in his left hand, as well as pain in the forearm when he does strenuous work. What really concerned him, though, is that in the last few episodes he has also experienced transitory vertigo, blurred vision, and difficulty articulating his speech. Let me backtrack here for a second, because if you read a question on the exam that says when a patient uses and exercises the arm complains, and that's all there is, you should be thinking of a thoracic outlet syndrome. It's a patient who has a cervical rib or a scalene muscle, that's very big, that sort of thing. But here we have a combination. When this gentleman exercises the arm complains, but also the back part of his brain complains, because he has blurred vision and vertigo. And this is a classical combination you should recognize as the subclavian steal syndrome. What this individual has is an arteriosclerotic plaque at the origin of a subclavian artery before the takeoff to the vertebral. There is enough flow through this narrow area to supply the needs of an arm that is not exercising. But that arm cannot get enough blood if it is being used. And in that case, the arm steals the blood away from the brain by reversing the flow in the vertebral artery. And thus the name, the vertebral steal syndrome, subclavian steal syndrome. And we can do an arteriogram that will demonstrate the reversal of flow when the man exercises the arm. And then a surgical bypass resolves the problem. So this condition was a subclavian steal syndrome, in which there is reversal of flow in the vertebral artery. A 62-year-old man is found on physical examination to have a 6 cm pulsatile mass deep in the abdomen between the xiphoid and the umbilicus. This is an abdominal aortic aneurysm. Typically, they are like this one, namely, they are asymptomatic. They are found. They are found on physical exam. Or they are found on a sonogram that was done for another reason, or found on a CT scan. But the significance is that if they are big enough, these aneurysms have a tendency to rupture, and then there is a very high morbidity and mortality for the patient. So we like to repair these aneurysms if they have attained the size where rupture is quite common. And so the next thing we need to do on this particular vignette is to have precise measurements of the aneurysm, because what you read here is feeling the abdomen. We felt the pulsatile mass, and hands that are feeling through the abdominal wall cannot really say this is exactly 5.5 cms or 6.2. And a sonogram will give you that information at a very limited cost. So that the next thing you want to do in this particular gentleman here is to do a sonogram. Now let me point out the parameters that lead to intervention. Everybody agrees that if an abdominal aortic aneurysm is 6 cms in diameter or bigger, it absolutely has to be repaired electively. And most people agree that below 4 cms in diameter, we can safely observe that aneurysm, and if it is growing, then intervene. So between 4 and 6, you have the more debatable area, but I have to point out to you that more and more reports come out advising the repair of aneurysms that are 5.5, and even the repair of aneurysms that are 5 cm. So eventually the gold standard will be 5 cms or more we have to repair. Although for many years the classical number has been 6. Now let me alert you to some other features that you might find in a patient with an aneurysm. A 62-year-old man has vague, poorly described epigastric and upper back discomfort. He's found on physical examination to have a 6 cm pulsatile mass deep in the abdomen between the xiphoid and the umbilicus. The mass is tender to palpation. Now remember that we said typically an aneurysm is completely asymptomatic. If this patient already has some discomfort and it is tender on palpation, this aneurysm is about to blow up. It's already beginning to leak a little bit, and there is now urgency in the situation. You still have time to do a sonogram because it doesn't take very long to do that, but a vascular surgeon needs to be consulted immediately, and that vascular surgeon will not want to wait a day or two. That individual will want to operate that patient as soon as possible because pretty soon this is going to be ruptured. But it could be even worse. Let me read you another vignette where the rupture is in fact happening. A 68-year-old man is brought to the ER with excruciating back pain that began suddenly 45 minutes ago. He's diaphoretic, has a systolic blood pressure of 90. There is an 8 cm pulsatile mass palpable deep in the abdomen above the umbilicus. This aneurysm is already leaking. Now, it hasn't blown up in the anterior wall because had that happened, the patient would be dead. He would have exsanguinated into the peritoneal cavity. But this gentleman already has a huge retroperitoneal hematoma, where the aneurysm has already bled into the retroperitoneal space. That gives him the horrible back pain, and if nothing is done right away, he will very, very soon die. So this gentleman needs immediate emergency surgery. You probably could do a sonogram in the OR while you are preparing the abdomen, but you don't want to wait. This is already a rupturing aneurysm. Now we move to arteriosclerotic occlusive disease affecting the lower extremities. The early symptomatology there, as you know, is intermittent claudication, which we typically describe by the distance the patient walks before the pain stops him from walking. The wealthy retired man has claudication when walking more than 15 blocks. Now let me say a few things before we proceed with the management here. There is one prediction you can make about claudication. If the patient smokes and continues to smoke, the claudication will get worse. If a patient stops smoking, there is a better chance that the claudication might not get worse. But except for that link with smoking, otherwise the future of a patient with claudication cannot be predicted. So you cannot say to this patient, oh, I'm glad you came to me when you have claudication at 15 blocks, because if you had come 3 months later, you wouldn't have been able to walk from here to there. That's not true. We don't know that. That could happen. But on the other hand, the man could go another year or 2 or 5 years without getting any worse. And so the bottom line is that we do not intervene in intermittent claudication unless it is affecting the lifestyle of the patient. Well, let's read this vignette again. Wealthy retired man. He doesn't have to go to work. He has plenty of money in the bank. He gets a claudication when he walks more than 15 blocks. Why does he have to walk 15 blocks? And so the advice to this gentleman is you shouldn't have an elaborate workup or even consider a surgical intervention, because this claudication isn't really interfering with your lifestyle. If he smokes, he certainly should quit. He would benefit from a program of exercise, and there is a drug called cilostazol that can be quite helpful in these cases. So that would be the program for this individual. But now let's contrast that with the next one. A 56-year-old postman describes severe pain in his right calf when he walks 2 or 3 blocks. The pain is relieved by resting 10 or 15 minutes, but recurs if he walks again the same distance. He cannot do his job this way, and he does not qualify yet for retirement. So he's most anxious to have this problem solved. He does not smoke. Well, the easy answer, which would have been stop smoking, is not applicable here, and he certainly has enough trouble to justify intervention. So here is the first thing we do. We start with non-invasive Doppler studies, where we measure blood pressure at various points in the body to see if there is a pressure gradient. So this first study we're going to do might appear in your exam under the words "do Doppler studies looking for a pressure gradient," or it might be expressed in a little different way by saying establish an ankle brachial index, which is the same thing. You do the pressures, measure the pressures with the help of the Doppler machine to see if the pressure at the arm and the pressure at the ankle are the same or they are not. Now, if we do not find the pressure gradient, that means the disease is affecting small arterioles and is not amenable to surgical intervention. But if we find the pressure gradient, then we proceed with an arteriogram to see exactly where is the block and what's the status of the vessels beyond and so on to plan an intervention. And then after that arteriogram has been done, we do the appropriate intervention, which might involve a bypass. When the disease is in the aortoiliac area, we may do an aortobifemoral bypass. When the disease affects primarily the superficial femoral artery, we might do a femoral-popliteal bypass using the saphenous vein as a conduit. And more, we are resorting lately to the use of angioplasty and stents. Originally, they were used only for very small segments, but we now have the means and the way to deploy stents after angioplasty for even longer segments. So we have a variety of things that we can do. But the workup, let me repeat, begins with the Doppler studies, and if there is a pressure gradient, then it follows with the arteriogram. Let me review this again, looking at a little bit of a decision tree. We're going to cut away from my face and go now to words on the screen. So the topic is claudication, and we have to be sure that it is claudication that interferes with lifestyle. Otherwise, there is no call to be evaluating the patient any further. We start with the Doppler studies, looking for a pressure gradient. You might find this described as establishing an ankle brachial index. If there is no pressure gradient, it's not a candidate for surgery or angioplasty or stents, and the medical management is the only option, which would include stop smoking, exercise program, and cilostazol. But on the other hand, if that claudication that interferes with the lifestyle, when we start with the Doppler studies looking for the pressure gradient, we find the pressure gradient, then we follow the arteriogram. And then, guided by the arteriogram, we do either the surgical bypass or the angioplasty and stents. And I have a picture here that illustrates what an arteriogram looks like. And you see the vessel that is open at a point and then is not open. There is a gap, in fact, there in the superficial femoral. Well, we're going to continue with a few additional vignettes before we go back to some pictures. A patient consults you because he, quote, cannot sleep. On questioning, it turns out that he has pain in the right calf, which keeps him from falling asleep. He relates that the pain goes away if he sits by the side of the bed and dangles a leg. His wife asks that she has watched him do that, and that she has noticed that the leg, which was very pale when he was lying down, becomes deep purple several minutes after he's sitting up. On physical examination, the skin of that leg is shiny, there is no hair, and there are no palpable peripheral pulses. This is obviously a problem which we refer to as rest pain. You might wonder, why isn't this pain present when the patient is walking? Because the patient doesn't walk anymore. This man has already learned he cannot go from here to there without pain. He has organized his life so the bed is here, the chair is here, the TV set is here. And he goes from one to the other. During the day, when his mind is active with other things, he doesn't feel the pain as much as he does at night when he's trying to go to sleep. And that's typically the presentation. Well, there is no question this man needs help, and you know how to proceed. Start with the Doppler studies, looking for a pressure gradient. If there is no pressure gradient, you go to the exercise program, the cilostazol, because it's not a candidate for surgery or angioplasty. But if you find the pressure gradient, you follow with the arteriogram, and guided by the arteriogram, do the appropriate surgical bypass or angioplasty and stenting. A 45-year-old man shows up in the ER with a pale, cold, pulseless, paresthetic, painful, and paralytic lower extremity. The process began suddenly 2 hours ago. Physical examination shows no pulses anywhere in that lower extremity. Pulse at the wrist is 95 per minute, grossly irregular. Here is the key to the diagnosis in that very last line, because grossly irregular pulse should immediately bring to you the thought of atrial fibrillation. Now remember the case we talked about earlier? An old man with atrial fibrillation who suddenly gets abdominal pain, and how that was a clot that went to the superior mesenteric artery and plugged it up. This is the same. Except the clot in this case went to the aortic bifurcation and stopped the perfusion in one of his legs. Well, this used to be a very difficult problem to deal with, because the aortic bifurcation is at the level of the umbilicus, and to extract that clot we had to do a big operation to get back there. And then came a gentleman by the name of Fogarty, who made a wonderful contribution, in fact, when he was a senior medical student. And he invented a catheter that now has his name, Fogarty catheter. It's a long catheter, fairly stiff, with a little balloon at the end that can be inflated or deflated from the end of the catheter. So now we make a small incision in the groin under local anesthesia, find the femoral artery, introduce the catheter, push it up backwards up into the aorta. And once that catheter is beyond where the clot is occluding one side of the aortic bifurcation, we inflate the balloon, we pull back, and in this fashion we retrieve the clot and open the vessel, which can subsequently then be repaired where we made the incision. So the Fogarty catheter has made much simpler the management of a patient like this. I might add that the Fogarty catheter is now extensively used in vascular surgery. Every time we do a vascular intervention, at the end, we know there is a little debris that we have left in the vessel. We clean that out with Fogarty catheters. We also use to our advantage newer technology in a patient like this. In a patient like this that might show up, we might do Doppler studies to find out exactly where is the obstruction and is it complete or incomplete. In a partial obstruction, we have the option of using clot busters. In a complete obstruction, we typically would do the embolectomy with a Fogarty catheter. And maybe I should add another detail. If you get a question like this on the exam, and it's clear from the question that many hours passed from the time when the patient first had the symptoms to the time you're ready to do the embolectomy, that means that leg has been ischemic for many hours. When we reestablish perfusion a compartment syndrome could develop in the lower leg. And so in that setting, one might add a fasciotomy at the end of the embolectomy. We have one more vignette dealing with vascular disease, and then I'm going to show you another couple of pictures. A 74-year-old man has sudden onset of extremely severe tearing chest pain that radiates to the back and migrates down shortly after its onset. His blood pressure is 220/110, and he has unequal pulses in the upper extremities and the wide mediastinum on chest X-ray. EKG and cardiac enzymes are negative for MI. This is a dissecting aneurysm of the thoracic aorta. So the presentation at first suggests a myocardial infarction. An old man with horrible chest pain of sudden onset. But it turns out that it is not. The EKG doesn't show that it's an MI. The cardiac enzymes, including the troponin, are negative. And then we realize that there is that wide mediastinum. In the context of a trauma vignette, the wide mediastinum would suggest to you the traumatic transection of the aorta. Here, it suggests to you the dissection of the aorta, the dissecting aneurysm. And like we had suggested as the best next step in the case of a traumatic transection of the aorta, the study you want to follow with is the spiral CT scan of the chest. And that spiral CT scan probably will show you exactly what is happening. And the general rule for management, obviously there are exceptions, but a general rule for management is if the dissection is in the ascending aorta, we do surgery to repair it, and often we have to repair the aortic valve that sometimes the dissection damages. But the rule is, again with exceptions, the rule is that if the dissection is in the descending aorta, we typically put the patient in the ICU, control the hypertension medically, and let the healing process proceed without a surgical intervention. Let me add, we are reluctant to operate on the descending aorta. Among other things, because the spinal cord gets its blood supply from little perforating vessels that come off the descending. If we clamp the descending aorta for a number of hours to do a lot of work, the patient might wake up with paraplegia. And so we are reluctant to operate in that area. Let me show you a picture or two that will conclude then our review of vascular procedures. Here is an aneurysm of the thoracic aorta, and we have another view showing the aortic dissection. And this concludes the chapter on vascular surgery.